welcome everyone to this AO Spine Fellows webinar. My name is Uichu Adago, and my co-moderator is Dr. Menga. We'll be discussing surgical planning of spinal deformities, taking you through some didactics, and as well as a very interesting case by Dr. Menga. I am an assistant professor of neurological surgery at the University of Cincinnati and associate residency program director. Dr. Menga is well known to all of you on this call. He's the chief of spinal surgery at Rochester. He's the fellowship director, associate residency program director, as well as an associate professor of orthopedics and neurosurgery. Certainly a good friend of mine and someone I lean on when I have complex cases to review. These are some upcoming webinars that if you feel so inclined, you should attend. Some really good ones coming up. May 2nd, you have this lumbar 3-column osteotomy, and then you have the kickoff for the fellows August 15th. Here's another webinar coming up on May 24th. Complications and legal ramifications of spine surgery. You can see the moderators there, and the title for the August 23 webinar is still to be determined. AO Spine is an independent nonprofit surgical specialty society dedicated to improving the care of patients with musculoskeletal injuries. It does not endorse nor promote the use of any products, service, or commercial entities. Equipment used in this course is for demonstration and teaching purposes with the intent to enhance the learning experience. This is the overview for the program today. We have some welcome introductions, which we've conducted with myself and my colleague, Dr. Menga. We'll give you some didactic presentations. We have a case presentation. We'll answer some questions, and then a quick summary and wrap up, and then we'll have you out at 9 p.m., hopefully. These are the objectives. How do you think about deformity? What are the key radiographic parameters that you should understand? You should be able to understand this idea of functional anatomical classification and the implications for deformity surgery, and certainly develop surgical strategies for correction of adult spinal deformities, both in the coronal and sagittal planes. I have no financial disclosures, and I'll be discussing nothing that is investigational in my presentation. So as we know, the demographics are changing. You look at the projections through the years 2050, and the fastest growing subpopulation of patients are going to be over the age of 65. And if you look at the older adults over the age of 85, those percentages are growing exponentially. What that means is patients are living longer, and they are developing spinal deformities for multiple different reasons. And this paper that was published in 1982, I think still holds true today, where they estimated the prevalence of adult spinal deformity to be about 70%. And Schwab and co, in their study, they found 68%. And I argue that this number might be north of 70, 80%, given the increased life expectancy in the older adult population. So this is a case. This is some of the things that you would see and you have seen in your practice. This is a patient who underwent surgery in the community and was sent to me when I was in Dallas. You could see the first reconstruction to your far left. They extended it one level up. And then they decided to do a lower thoracic to sacrum fusion with iliac fixation. The patient was still having problems. She developed some proximal junctional kyphosis and needed an osteotomy to rebalance the spine. So how do you think through a problem like this? What's the driver of the deformity, and how do you correct it? Some of the things that we'll be discussing today. This is another case that was sent to me with a semi-iatrogenic deformity. This patient had 5 previous spinal operations. She had a sagittal plane malalignment. She had a mild coronal plane malalignment, although the hips and the shoulders appear to be balanced. The right shoulder, left shoulder is slightly elevated. She was fused at L4 and L5 when she needed an osteotomy. I don't have a pro-axis table, so I use segmental correction, and I think it's a nice technique, not just to balance the spine in the sagittal plane, but also allow you to correct the coronal deformity without having to do an asymmetric pedicle subtraction osteotomy. She's well balanced, and I saw her in clinic, and she's over close to a year now, and she's doing very well. This is another one, 46-year-old lady. This is what we typically see. You see that axial screw there. She had 6 prior operations. I'm presented with severe low back pain. She had a spinal cord stimulator placed. She had very significant sagittal plane malalignment. Past medical history was notable for DVTs and PEs. So overall, a very medically complex patient. And she's 46, and she's being told that there's nothing that can be done for her. So we saw her, we optimized her, we got her, surrounded her with the right team, and we performed an osteotomy, and we're able to balance the spine appropriately. She's over a year now, and she's doing very, very well, pain-free, using Tylenol occasionally. And this is a 56-year-old gentleman, stenosis. This is an adult degenerative scoliosis. You could see he's balanced in the sagittal and coronal, sagittal in the coronal planes. He was off slightly in the sagittal plane. His main complaint was stenosis and radiculopathy, and you have to think about how you reconstruct the spine in a case like this without throwing his shoulders off, which is what we're able to do. We're able to do a lower thoracic to sacrum fusion with iliac fixation supplemented by an L5 S1 A-lift, and we're able to balance the spine. His left shoulder is slightly elevated, but I think if you look at the T1 bridge, you can see that he's actually balanced in the coronal plane. And this is one that I was thinking about this case when I was talking to Benga last night. This is one that I wish I had done executed on my original plan. And another lady who had been seen by the community, several spine operations, comes in with profound sagittal plane malalignment, mild coronal malalignment with a right trunk shift. And my plan initially was a L4 osteotomy, pedicle subtraction osteotomy. She had T-lifts, laterals at the levels above. And when we positioned her on the table, she had a T1 PA that was about 16 degrees, so not perfect, not less than 14. And I thought that given that T1 PA and given how she looked on the operating room table, that we could potentially just do some posterior column osteotomies and try to shorten posteriorly. And you can see when she stands, if you look at the obturator views, she's still retroverted. I use the gravity line, and you can still see that her knees are flexed. So the story isn't fully told in this one yet. And this is one that I wish I could have a go at it again, because I think I would really stick to my original plan of doing a pedicle subtraction osteotomy, maybe at L4. So when you think about adult spinal deformity, very different from pediatric deformity. The drivers are de novo degenerative processes, like I've showed you. Adolescent scoliosis in adults, iatrogenic, which we see a lot of now. You're all going to see a lot in your practices. Oncologic and infection, and these are quite different from what you see in the pediatric patients. The reasons for surgery in these patients are also quite different. Progressive pain, neurological deficit, radicular pain, spinal decompensation, and these patients have engaged so many compensatory mechanisms that, unlike the pediatric patients, which are mostly for cosmeses, the quality of life of these patients is quite poor with the degree of deformity that they have. So when I see a patient, any of those patients that I showed you, this is what I'm thinking about. In clinic, I'm assessing these patients, watching them ambulate. I'm laying them on my table to make sure to get a sense of their degree of passive correction. Every patient gets upright and recumbent films. I want to know, is it a fixed deformity? Is it a flexible deformity? I'm looking at their knees, looking at lateral bending films. If I'm concerned that I have a fixed biplanar deformity that I need to take care of. I always get CTs on MRIs in every patient, looking for those vacuum discs. Sometimes you might have end plate contact and severe arthrosis in the facet joint with some hypertrophy, but you can still see, if you get an ICT, get a CT scan, there's still some vacuum disc that allows you to correct your deformity in the coronal plane. For all my older adults, I get a DEXA scan. We're going to be challenging their bones. So I want to make sure the bones are strong enough to withstand the implants, and certainly some of the technical nuances and the challenges that we're going to put forward to them. I surround these patients with a multidisciplinary optimization team. So they have nutritionists, pain psychologists, geriatricians, social work, pain management, everything you need to really circumferentially get these patients ready for an operation. And I pay very close attention to this concept of chronological versus physiological age. It's something that we're studying in the laboratory. There are multiple ways to do this. Some people have used telomere length. Some people are using DNA methylation, which is what we're sort of think of using. And you look at the patient. Somebody might be chronologically 60, but physiologically 80. Those are the patients you want to take a step back on and really have optimized. The key thing with any of these deformities, if you fail to plan, you should plan to fail. Because in the operating room is the last place you want to be changing your plan. You want everything to be thought through and just ready to execute in the operating room. Again, in the clinic, I want to see how flexible they are. I assess the extensive muscular strength. I have all these patients squat and see if they can come up. Again, just assessing overall physiologic fitness for an operation. So a lot of the concepts we're going to discuss today are mostly conversation points. I'm not going to give you any hard and fast rules, but just strategies to think about deformity in the coronal and sagittal plane, and questions that you should be asking yourself and asking us as attendings, questions you should be asking to elevate our game and move the ball up court. How do we do these operations better? How do we execute better? And how do we get better results radiographically and certainly clinically? So this is borrowed from Pierre Roussely's book. I rounded up my training with Pierre Roussely in France, and he really brought me across the finish line in how to think about sagittal plane deformity. This book, if you don't have it, I recommend that you all get it. But anyway, you can see that we've been discussing scoliosis for a long time, from the days of Hippocrates to Percival Potts, who was interested in TB and kyphotic evolution, to the work that Pierre Roussely's mentor Pierre Stagnaro was conducting. We've been discussing sagittal and coronal plane deformities for a long time. In 1985, there was a mathematician named Durin who was really the first brain behind the PI, pelvic incidence, sacral slope, and pelvic tilt equation. He was a mathematician, and so when he paired up with Legaye and Bouparé, they were able to come up with the concepts now that we call pelvic incidence, sacral slope, and pelvic tilt. Fast forward to SRS Sharp classification, and what they did was to say, look, can we narrow it down and give people a recipe to reconstruct the spine with? And then what I think is the next evolution of this, which I'll discuss briefly, was in 2006 by Bethano, when he talks about this idea of functional anatomical segmentation, which is how I think about deformity today and how I'll encourage you to think about it. So when you think about the physiological changes that happen with alignment, your skull, the cranial vault with your brain, weighs anywhere from 15 to 11 to 16 pounds. And then you superimpose on that the trunk, and you look for a female here, head and trunk. The forces that she's generating is about 350 newtons. So if you look at the lever arm, when she is 10 centimeters off in the sagittal plane, and that's obviously as she ages, you can see that lever arm is much greater. So what we're asking the spine to do at the base of the spine, as we have sagittal plane deformity, increases the lever arm and the stressors that we see at the lumbopelvic area. So when I think about deformity, I start from the lumbopelvic area and I work my way up. Some folks can start globally and then work their way back. Just pick a rhythm and pick a way that you want to do it and stick to that. So I start usually with the lumbopelvic assessment. All of you are familiar with these terminology. Pelvic incidence, as you know, does not change in adulthood. That's the angle between a line drawn from the bicoxofemoral heads and a perpendicular line drawn to the sacral end plate. It ranges anywhere from 30 and the very low end to 80. I shy away from giving you any specific numbers here, because as you would see, the pelvic incidence is really a signature, not just of how much lumbar lordosis you need, but where you need to put the lumbar lordosis. Pelvic tilt and sacral slope, these are compensatory mechanisms that we engage. The pelvic tilt, as you know, is the angle between a vertical line from the bicoxofemoral head and a line drawn to the sacral end plate. Again, this, in an ideal world, you want to keep this pelvic tilt less than 20. And then the sacral slope is is the angle between a horizontal line and certainly a line drawn along the sacral end plane. The equation that we've been given to sort of think through this is the pelvic incidence, which is fixed, is equal to the pelvic tilt and the sacral slope, meaning there's an inverse relationship with increased sacral slope and decreased pelvic tilt. This is one of the first take-home points I want to leave you with. So if you don't remember anything, the first couple slides, remember this. Pelvic incidence is really measures the ability of the spine to retrovert itself, meaning what the potential of the spine of the pelvis for retroversion. It is a phenomenon on high PI patients. If you have a low pelvic incidence, these patients have less ability to retrovert and compensate. High pelvic incidence, they have a higher ability to retrovert and by definition compensate. So what does that mean? If you have a high PI patient, they might still be able to compensate after your an operation that is maybe suboptimal. If you have a low PI patient, these are the patients that you really want to try to balance appropriately because they have less ability to compensate. So very important point, this relationship between pelvic incidence and pelvic tilt. Pelvic tilt is a phenomenon of high PI. The next thing that you think about is anatomically is this regional and segmental assessment is lumbar lordosis. You all know how to measure this. And ideally, based on the Sharp classification, you want to keep the lumbar lordosis pelvic incidence to less than a mismatch of 10. If it's greater than 10, that symbolizes that the patient is compensating and they're doing a bit more work. You know, think about the thoracic kyphosis. Pay attention to the thoracic kyphosis. It's very important as you start thinking about your UIV. A patient who has profound thoracic hypokyphosis might be at a higher risk of proximal junctional kyphosis compared to a patient who does not. So really think about the thoracic kyphosis when you're thinking about your sagittal plane malalignment, as it gives you some information of where you need to stop, you place your UIV. If you think that you can lose control of the thoracic compensatory mechanisms once you've addressed the lumbar spine, then that's probably something you should cover and go up to the upper thoracic spine with your instrumentation. So now you've thought about the lumbopelvic area, you've thought about segmentally, and now you want to think globally. How do you assess global balance? There are multiple ways to do this. Obviously, the SVA is one of the classic ways that we do this. The key thing is to remember that the SVA is a radiographic parameter and does not tell you anything really about the patient's balance. You want to keep the SVA less than 5. This is a line drawn from the centroid of C7 caudally, and you have a horizontal line drawn from the posterior superior end plate of the sacral plate to the SVA. You want to keep that number less than 5. A more important measure of global alignment, I think, is the T1 pelvic angle. And I think this is important because it measures not only the spinal inclination, but it also captures any abnormalities in the pelvis, so pelvic retroversion. And that seems to be, this T1 PA angle is stable and steady, independent of whether you're standing or you're supine or you're prone. So you can use this information intraoperatively, you can use it preoperatively, you can use it intraop to confirm your alignment targets, and certainly postoperatively, it's a good measure to track, and you want to keep that number less than 14. Personally, when I think about the SVA and sagittal plane malalignment, I use the gravity line. As I mentioned, the SVA is purely a radiographic marker of apparent global alignment, while the gravity line obtained from a force plate represents really the true center of forces in the standing subject. So I use the external acoustic meatus, draw my gravity line, and that's what I use to assess my sagittal plane correction. So the other key point to take away from this up until this point is that the gravity line and the C7 plumb line, not the same. The C7 plumb line is a radiographic parameter. The gravity line is a better measure of overall balance and force distribution in your patient. The Berry ratio is another way to think about this. In this case, they're looking at balanced, slightly unbalanced, and an unbalanced spine. You really want to keep this ratio less than 0.9. And the way I think about sagittal plane malalignment globally, which is what I'll encourage you to think about, is just simplifying it. move away from SVA, move away from all of these, you can help you understand what's going on sagittally. But really what I think about it is, are the patients balanced? Are they balanced with compensation, or are they unbalanced? A patient that's balanced have a cranial line, a line drawn from the cranial vault through the behind the femoral heads and ventral to the posterior superior end plate of the sacral of S1. If they have no pelvic retroversion, and that line runs between the femoral heads and the posterior superior aspect of S1, these patients are balanced. If that same line runs between the femoral heads and the posterior superior end plate of S1, but the pelvic tilt is greater than 20, then these patients are balanced with compensation. Very, very important concept. And if they have the same line that's anterior or ventral to the femoral heads and the pelvic tilt is greater than 20, then these patients are not balanced. So I've simplified it in my mind, and I teach my residents this. SVA is important, but if you think about this way, it really simplifies this. Is the patient balanced? Look at the plumb line, look at where it falls, look at the pelvic tilt. If the pelvic tilt is less than 20 and the plumb line falls exactly where you want it to fall, then the patient is balanced. Are they balanced with compensation, pelvic tilt greater than 20, or are they not balanced, which means the plumb line falls in front of the femoral heads and the pelvic tilt is greater than 20. So that's that's how I assess sagittal plane and how I try to reconstruct in surgery. So there are some new concepts that I mentioned earlier from Bartholomew and Rusali and so on that we'll be discussing next. And I think this is the next iteration in how you think about sagittal plane deformity. This is probably the most important slide that I want to leave you with today, this idea of functional segmentation. If you recall, we said pelvic incidence equates to pelvic tilt and sacral slope. And you could see here on this figure that the sacral slope from basic trigonometry is equal to the lower arc of lumbar lordosis. So you take your global arc of lumbar lordosis, you find that apex, you divide it into an upper and lower arc, and beta, the lower arc, represents the sacral slope. Theta, the upper arc of lumbar lordosis, is equivalent to the lower arc of thoracic kyphosis. And you find the apex by drawing a diagonal line from you find the inflection point by drawing a diagonal line from the apex of the lumbar lordosis and connecting that to a diagonal line from a horizontal line from the apex of thoracic kyphosis. So very important. Beta, the lower arc of lumbar lordosis, is the point between the inflection point and the sacrum, and that equals to the sacral slope. The upper arc of lumbar lordosis is the apex to the inflection point, and that's theta, and that equates to the lower arc of thoracic kyphosis. So by definition, if you want to change the sacral slope, you have to change beta. You have to change the angulation between the apex of lumbar lordosis and the sacrum. Any work done in the upper arc of lumbar lordosis does not change the sacral slope. However, it changes theta, which is the lower arc of thoracic kyphosis. Very, very important. If you do any work, X-lifts, anterior column release on the upper arc of lumbar lordosis, you set yourself up for potentially proximal junctional kyphosis because you're throwing off the lower arc of thoracic kyphosis, and you're going to have a compensatory kyphotic kyphosis in response to your lumbar correction. So we know the pelvic tilt greater than 20 is pathologic, and we know that there's an inverse relationship between pelvic tilt and sacral slope. So how do you decrease pelvic tilt? You have to change sacral slope. How do you change your sacral slope? You change the angulation between the apex and the lower and the sacral plate, or beta, which is the lower arc of lumbar lordosis. So the key take-home point is your corrections should be always between the apex and the sacral slope on the sacral plate, because it allows you to change beta, and that allows you to change the sacral slope. So this is the relationship we're talking about. To increase the sacral slope, you want to change beta. That would decrease your pelvic tilt. That decreases the risk on the rates of mechanical failures. So, as you know, over the last few years, there's been discussion of spinal morphotypes. And this is a lot of work from Pierre Rusali, and which is how I think about this now. And this idea that we don't all have the same shape, that we all have different shapes, and that if you can understand the pelvic incidence, it doesn't only tell you information about how much lumbar lordosis you need to dial in, but it's also a signature for where the lumbar lordosis ought to be. So this is the Rousseli classification I'm going to just briefly introduce you to. This was initially done with sacral slope. So patients with a sacral slope less than 35, these were type 1 or type 2 patients. Type 1 patients have a very short, low lumbar lordosis that quickly goes into thoracic kyphosis. These are the patients that if you need to do an osteotomy on, this is your L5 PSO. Type 2 patients, these are the physiologically flat back patients. They load through the anterior column. These are the young patients who develop multi-level disc herniations before the age of 40. These are the main drivers of de novo scoliosis and rotatory subluxation because they load through the anterior column. Type 3, this is most of us, right? We balance between the anterior and posterior columns. And so these patients might have symmetric degeneration between what you see anteriorly and also the facet capsules. Their sacral slope ranges anywhere from 35 to 45. And type 4, these are the types of patients that have really exaggerated lumbar lordosis or thoracic kyphosis. If some African-American women, for instance, have this hockey stick type looking spine, they have exaggerated lumbar lordosis. And when they start losing that lumbar lordosis, the compensatory mechanism sort of transforms this type 4 into a hockey stick. These are the patients that you see, young patients who come to you with excruciating back pain, worse with extension. They're usually type 4 patients. Sacral slope, the sacral slope was calculated in normal asymptomatic patients. They have now converted it to pelvic incidence. So when I think about PI using this classification, this is what I think about. PI of less than 50, I'm thinking type 1 or type 2. Again, less ability to retrovert the pelvis, less ability to compensate. These are the patients I try to get my correction spot on perfect. Type 3, PI 50 to 60. These patients have an ability to compensate. So oftentimes you've heard about the concept of a false type 2 or Rousseli type 2. And this just means that these patients are theoretically a type 3, but we fuse them with some with a pelvic with a sacral slope that puts them into type 2 category. And so we're thinking about these patients as the false type 2, when in reality they should be a type 3. And then type 4 patients, I put these patients, with a PI of over 60. These are x-rays that Mr. Rousseli shared with me, so showing you these different morphotypes. And this is how they fail. And I encourage the fellows, as you go through your x-rays in clinic, you should think about looking at these patients and looking at the x-rays and seeing, based on the PI, whether they fail. If you have a type 1, they usually fail in the really low lumbar spine. They also fail around L2, L3, right? L2 is retrolisthesis and L3. That's how I tell a type 1 from a type 2 in patients with low pelvic incidence. I look at where they have facet arthropathy and hypertrophy. I look at what's happening at L2, L3. If I see that retrolisthesis and this early conversion to thoracic kyphosis, I'm thinking that these patients are type 1. Type 2, flat back, physiologic flat back, multi-level degeneration. These are the young patients who presents with a lot of discogenic pathology early on. And then type 3s is symmetric, so you would see some disc degeneration, but you'll also see some facet pathology. And what does this mean? It means that the higher the PI, the higher the inflection point. So you would, for type 1, the inflection point is usually at the mid-body of L5. Type 2, it's at the L4 and L5 disc space. Type 3 is at the mid-body of L4, and type 4 is at the mid-body of L3. So the higher the pelvic incidence, the higher the inflection point. That's another take-home point that I want you to sort of take away from this. And so when you think about alignments, in addition to thinking about this, the recipe that Schwab and the SRS has given us in keeping SVA less than 5, keeping the pelvic T1 tilt less than 0, pelvic tilt less than 25, and keeping the PI-LL mismatch less than 10, I want to encourage you to also think about the Rousseli type. I want to encourage you to think about that using the T1 PA that Dr. Manga will talk to you about shortly. I want to encourage you to think about where you place your plumb line and how you place your plumb line and where you want to get the ultimate correction. And I'll also encourage you to think about this phenomenon of upper versus lower arc of lumbar lordosis. So if you're doing an ALL release and at L2, L3, that's the upper arc of lumbar lordosis. You're going to have a setup for a proximal junctional kyphosis because you're affecting the lower arc of thoracic kyphosis. So keeping your reconstructions between the apex and the sacral end plate, using that as the workhorse to correct your sagittal plane. I'd like to encourage you to think about that. So in summary, when I think about sagittal plane deformity, I think about measure the lumbopelvic angles, understand this intimate relationship between pelvic incidence and pelvic tilt, understand where the thoracic kyphosis comes into play. A patient with strong extensor muscles and you're unsure how the thoracic spine is going to respond once you correct the lumbar lordosis or give them adequate lordosis, that's one that you might think about taking a UIB to the upper thoracic spine versus a patient that has a more predictable, that may have a more predictable response to correcting the lumbar deformity. You can use the SVA, think about where you draw your plumb line, understand this concept of balance, compensated balance, and imbalance. That's what I use now. Is the patient balanced? Are they balanced with compensation? Are they not balanced? I try to balance every patient as much as I can because I think it's helpful. Think about this concept of functional anatomic segmentation. Understand the Russelli morphotypes. I think it's helpful, and certainly this concept of fixed versus flexible deformity. In a few minutes, I'll go through the coronal alignment principles, and then we'll turn the stage over to Dr. Manga to go through a case. So coronal alignment, this has been underrepresented stepchild. I borrowed some of these slides from my colleague, Alekos Theologis, wonderful guy. So I want to give him credit for some of these slides. Coronal malalignment, underrepresented stepchild of spinal deformity. As you could see, we haven't really paid much attention to it until very recently, and we realized that the more coronally malaligned you are after your correction, the higher the rates of implant failure, and obviously these patients have an inferior quality adjusted life year. So I measure the coronal balance distance in all my patients. And that's that line between the plumb line as well as and this CSVL. You want to keep that less than 3 centimeters. If it's greater than 3 centimeters, they tend to have some problems downstream. And this is exactly what this is saying. This is a paper from Glassman's group showing that when the coronal malalignment was greater than 40, that these patients had inferior quality adjusted, health-related quality adjusted life year parameters, and something you want to think about. So this is a classification system I want you to think about. This is what I use to assess my coronal balance. When I look at a patient, I say, is the shoulders balanced over the hip? I start there. Then I calculate the coronal balance distance. And then I ask myself, is it a type A, type B, and type C? Because that tells me where I need to do my reconstruction. In a type A patient, these patients have a coronal balance distance that's less than 3 centimeters, which you could see there. Shoulders are balanced over the hip. You don't have too much truncal rotation. So this is the type A patient. In this patient, you can build your construct from the sacrum and work at the level of the concavity, translate, derotate, lock in at the lower thoracic spine, derotate and pull the spine in, and that's all you need to do. In a type B patient, this patient have a coronal balance distance where the C7 plumb line is shifted towards the concavity. Same theory as type A. Build from the bottom, translate, derotate, locking your rod at the bottom at an L5 and S1, locking on the lower thoracic spine, T10, 11, 12, and then translate, derotate. You can use reduction screws, which I don't. I just translate, derotate with a temporary rod on the convexity, the lower aspect of the convexity, and I just use 2 rod grippers, translate, derotate the spine, pull the spine back, and then distract to balance of the coronal malalignment. In type C, these patients have a CBD greater than 3. The C7 plumb line is shifted towards the convexity. These are the hardest patients to correct because to correct these patients, you really need to do the correction needs to be at the fractional curve and not at the main lumbar curve. If you try to correct the main lumbar curve, you may not be happy with your ultimate correction. So in these cases, I really work on the fractional curve If I can do an A-lift, if I need to do an asymmetric osteotomy, if I want to do an L5 pediculectomy, these are the patients that I think about. This is the OBEID classification, which is sort of discusses briefly what some of the things that I've talked about, which is if you have a type 1 patient or type A, these are the patients where you want to think about performing your osteotomy and the correction really at the apex of the lumbar curve. For type B. For type C, you really want to focus on the lumbar sacral junction. Type A, I treat like a type B. Because I think when I start building my construct from the bottom, I can get type A's really nicely corrected. I can really correct type B. I really struggle with type C. So you really have to be careful with type C's. Pay attention to the lumbosacral fractional curve. This could either be your friend or your enemy. If there's a lumbosacral curve, really think about correcting it. Get a CT scan to try to, there's a vacuum disc that you can take advantage of. This is where you want to do an A-lift, usually at 5'1". I avoid doing A-lifts at 4'5" because of the concept of the upper versus lumbar arc of lumbar lordosis. And if it's fused, then this is where you want to think about either an asymmetric pedicle subtraction osteotomy at L5, or what I've done historically is just the pediculectomy on the convexity and compressed across the pediculectomy site to neutralize the fractional lumbosacral curve. And once you've got that neutralized, then you could treat this almost like a type A or type B. So in summary, when I think about the coronal malalignment, I think about the coronal balance distance. Is it less than 3? Is it greater than 3? Where do I have the problem? Is it a structural lumbar curve? Is the problem at the lumbar sacral junction? I think about the bowel classification versus the OBEID classification, and I really pay attention to that fractional curve because that can really hurt you. And I'll turn this over to Dr. Mega, who will take us through a case.
Yeah, thanks for the excellent presentation, Ochio, and thanks everyone for attending. Please feel free to submit questions through the chat or QA tab, or feel free to interrupt me if you have any questions. I would really like to keep this interactive. And I know Dr. Ochio just went over an extensive presentation on sagittal alignment and also some coronal concepts on coronal alignment and coronal deformity. So I'm going to present an example of a case. This is a lady I actually just recently did surgery on maybe 5 months ago, but started seeing the lady prior to COVID. So it's a 78-year-old female. And for the sake of time and knowing Dr. Ochio went through most of the sagittal parameters, I'll run through them and we can always discuss more at the end of the talk, or you can submit questions. So this is a 78-year-old female presenting with symptomatic proximal junctional kyphosis. Why do I say symptomatic? Because we know majority of patients with proximal junctional kyphosis actually are asymptomatic. So that's why, we're trying to focus now studies looking mostly at symptomatic proximal junctional kyphosis. So we talk about proximal junctional failure. So almost using terminology that implies the patient needs surgery, or proximal junctional fracture, or so there's a spectrum of PJK. But if you look at the studies with using 10 degrees as the definition for PJK, majority of the patients are actually asymptomatic. And if you look at outcomes, various outcomes questionnaires, the outcome is actually quite similar for those patients who are asymptomatic compared to patients without PJK. So this 78-year-old patient is presented with back pain, bilateral lower extremity radicular pain, with right leg weakness. She describes her right thigh and right leg giving out on her. Her history is significant for previous L2 to S1 posterior spinal fusion with interbody fusion. I'll show you the x-rays and CT scans and MRI. So beginning in 2019, so she had surgery, I think it was 2015. And in 2019, she was picking up a lift in Turkey, as you can imagine, during the Thanksgiving break. And she felt severe low back pain and pain down the left leg. So initially had strictly left-sided pain. But she also reported that since her surgery, she had continued, she started having symptoms with pain over the left buttock, left lateral thigh, left lateral leg, beginning roughly about 3 months after her surgery. But the pain has been on and off. But after this incident in 2019, she began experiencing severe pain. So she came to see me more for a second opinion. She had surgery done somewhere else here in New York. And I initially saw her in February of 2020. And as most of us recall, the country was shut down in March. So we did mostly telehealth visit. And the next time she actually came in for an in-person visit was in 2022, sometime middle of last year. So at this time, low back pain, radiating pain to the right anterior thigh, with right leg weakness and the right leg giving out whenever after walking, taking a few steps. Left buttock pain, left lateral thigh pain, and left lateral leg pain. Remember, I mentioned she'd been having this left-sided symptoms beginning roughly about 3 months after her previous surgery. Past medical history obtained, so DEXA scan from 2022 was she had a T-score of negative 1.9 with osteopenia, depression, hypertension, asthma. I mentioned the past surgical history, which was L2 to S1 laminectomy and posterior spinal fusion with interbody fusion at L3, 4, 4, 5, and 5, 1. On physical exam, so significant findings on physical exam. She was standing with a stoop posture with some retroversion of her hip extension, knee flexion. Based on exam, she was reporting right L2 radicular type symptoms and left L5 radicular, L5S1 radicular type symptoms. So 3 years of conservative management, but progressive difficulty with ADLs. And she drove to see us. Typically, I think her drive was almost about 4 hours. She lived in around the borders of Pennsylvania. So she would come to clinic with her son. And each time she came in, we've been trying to treat this non-op, and then COVID happened. But she felt she really could not tolerate her symptoms any longer and wanted to pursue something surgical or other treatment modalities we had to offer. So here's the X-ray that was obtained in 2022 when she came back for follow-up after the COVID restrictions. As you can see, she has the previous instrumented fusion extending from L2 to S1, and that's the most we can see. You can tell there's some form of failure going on here. The X-rays obviously is not great, but you can tell there's some screw cutout and failure at the top level. Yeah, we measured the proximal junctional angle. So the proximal junctional angle is the angle measured from the inferior end plate of the UIV, UIV being the upper instrumented vertebrae. So in this case, L2 is a UIV. So the angle measured between the inferior end plate of L2 to 2 end plates above the UIV. So there's a cutout, 2 end plates. So this, error in placement of the Cobb angle there, sagittal Cobb angle, but 2 levels above the UIV. And that angle, if the angle is greater than 10, is considered PJK, but also if that angle is greater than 10 compared to preoperative angle. So if this same patient prior to surgery had an angle of 15, and post-surgery still has an angle of 15 or angle of 18, that is not PJK. So it also has to be greater than the angle prior to surgery. And again, I mentioned symptomatic PJK because if you look at her angle, it's actually not very impressive. It's 14.9, which is just 4 degrees above the using 10 degrees as a standard. There's some studies that looked at that suggested using 15 degrees as a cutoff for PJK. There's some studies, Bridwell study recommended using 20 degrees as a cutoff for PJK. And the reason all these different angles are being suggested is because if 10 degrees is the suggests currently used angle, and most of these patients are asymptomatic, then what's the point of worrying about PJK if the patients are asymptomatic? So maybe we should look at angles that may lead to symptomatic PJK. But so far, the current definition for PJK, the most commonly used angle is a 10-degree angle. So you just, as what you, Dr. Adogwa mentioned, this T1PA, so the angle measured from the center of your T1 vertebral body to the center of your pelvis and to the center of the superior end plate of S1, and measures 26 degrees. And if you look at the studies, Dr. Preoperative from NYU and the ISSG did a very good study and recommended using 14 degrees as an ideal angle. And as you go up above 14 degrees, there's a significant increase in, so they correlated this with quality health related HRQOL, which is a health related quality of life. And so Ideally, you want that angle somewhere between 14 degrees, but you should also take into account the inter-observer and intra-observer reliability. As we know, with when we measure COP angle, we know we have a leeway between 4 degrees and 6 degrees as measured that we consider to be within the standard measurement error. So 14 degrees, if you're looking at 14 degrees, maybe 10 degrees to 16 to 18 to 20 degrees should be considered somewhere within the ideal angle. Dr. Odogro went through most of the spinal pelvic alignment. This is a busy slide when you look at sagittal parameters. So you have your T1PA measured in this slide, and you have added the so you see this you're measuring the C7 SVA with a C7 plumb line, and the SVA measuring 59.7, so that's 5.9 centimeters. We still have the 26 degrees for T1PA, and as I mentioned, ideally you want to have it somewhere around 14. We have the pelvic incidence for this patient measuring about 43 degrees. We know that's a fixed angle. Lumbar lordosis 19 degrees and thoracic kyphosis 30 degrees. So we have a PI minus LL mismatch here of roughly about 22 degrees. And we know ideally you want to have it somewhere between plus minus 9. So those are all different parameters you look at as you're looking at the global alignment and also the alignment within the lumbar pelvic region. So what other studies do we need? So for most of these patients, we'll pursue an MRI to evaluate for stenosis, which could be causing her radiculopathy, and you also get a CT scan. We take advantage of the CT scan now with use of Hounsfield unit. I mentioned the patient is osteopenic. I'm sure you've had experience during your fellowship where you go into surgery and the patient has normal bone on bone density, but then you put screws into the bone and it feels like butter, like there's no bone there. So the Hounsfield unit allows us to, gives us another measure. We know DEXA scan is the best we have, but it's not very accurate, especially for patients with deformity. And we're talking about spinal deformity and patients undergoing revision surgery. We know DEXA scan is not very accurate for those patients, so we take advantage of the Hounsfield unit. As you can see here, the Hounsfield unit, yeah, ideally you want it somewhere around over 130, 150, depending on the study you're looking at. Here it measured about 182 at the top at T10. So this is just going just some critical views looking at the different levels. So you have the L1-2 where she has the PJK. She has the calcified stenosis. So you have the calcified stenosis, that L1-2 likely compressing the on the right side, the traversing L1 nerve root, or L2 nerve root rather. And remember, I mentioned she had anterior thigh pain and some weakness with her hip flexor and with walking, which would correlate to stenosis within this region. You can also see she has a medialized right L2 medial screw, so that will be compressing the right L2 nerve root. Loosening of the S1 screws. And this is just a different view looking at loosening of the S1 screws. And remember, she mentioned beginning roughly about 3 months after her surgery, she began having left buttock pain, lateral thigh pain, lateral leg pain, which could potentially correlate to foraminal stenosis. I'm not sure, we couldn't get hold of the operative report whether BMP was used here, but you can imagine if there's calcification and compression of that nerve root, it can cause L5 radicular symptoms. This is just the MRI. You're looking at the stenosis at the L1-2 level. And just another cut down one level, just the next slide down showing further stenosis in the L1-2 level. And then also critical to evaluate for where the phylum terminale is, because this is someone, if you're thinking about doing an osteotomy or even just doing decompression, you have to be careful with retraction or with the amount of trauma you put in that area, because even though you're working within the lumbar spine, some patients have extension of the phylum terminale down into the posterior aspect of L2. So this is someone you could cause weakness or spinal cord injury with injury around the phylum terminale. So it's critical to pay attention to that, even when doing basic decompression cases within the upper lumbar spine. So this is just a quick view. So BMI 18.16, pretty healthy lady, non-smoker, non-diabetic. someone with other things to consider. Due to a thin body habitus, you have to also consider, and you can feel the prominent screw and also the prominence of the spinous process at the level of the PJK. So you have to consider plastic surgery for some paraspinal muscle flap for closure. So what are the options? You can consider non-operative management, which we did for 3 years, and COVID also helped with that. You can consider decompression only, but understanding that it doesn't change her alignment. Decompression and extension of her fusion, 1 and 2 level up, we notice a lot of calcification. So decompression alone and fusion may not correct the malalignment that she has, which is affecting her overall global alignment. Do you add pelvic screws? Do you revise the current screw she has with a loosening of the hardware? Do you perform an osteotomy? Whether it's a posterior column osteotomy or 3-column osteotomy to correct the deformity. So for the sake of time, and just so we have some time to discuss and go over some questions. So she's now 2 and the last time I saw her, this was that's 2.5 months. So that was just a month and a half ago. So what we ended up doing, I did a pedicle subtraction osteotomy. So remove the screw at L2, revised the loose screws, extended her down to the pelvis and up to T10, performed some cement bone augmentation due to her bone quality, and then performed a pedicle subtraction osteotomy, grade 4 pedicle subtraction osteotomy, which includes resection of the pedicle and also resection of the calcified disc at the level between L1 and L2. And I also placed some mesh cages. So I placed that as far anterior as I can. So there are actually 2 cages anteriorly to the side of the PSO, and I was able to correct her deformity and also improve her overall alignment. So this is just looking at her sagittal parameters post-op. So this is a T1 PA. We've improved that. If you recall, it was 26. So we've improved that down to 16. Ideally, as we mentioned, based on the study from Dr. Preoperative and the ISSG, it should ideally be 14. Pelvic incidence doesn't change. So if you recall, I measured 43, now it's 47. Is that different? No, it's likely within the standard measurement error. Lumbar lordosis is significantly improved. Her previous lumbar lordosis, I think, was she had a 20-degree mismatch, and now the mismatch is roughly about 3 degrees. Thoracic kyphosis also improved. And here are pre-op and post-operative images. All right, we'd like to open it up for discussion, especially since we're running out of time, so we can try to cover as much as we can.
So there's a question from Choma Theodore. Why not L5?
Why not L5 for correction of the deformity? So she's fused already at L5. So is an L5 PSO, is that an option? Yes, you can provide as much a much better lordosis at the L5 level. But also this patient's at the time of her surgery, she was 81 years old, and she has a deformity that needs to be corrected at L1-2. I think at L1-2, and also has and so I think, yeah, that's certainly an option if you want to be aggressive with correcting, getting more lordosis. But for someone this age, I think we also take into account their age and also understand that the goal sometimes not necessarily to make their spinal alignment or spinal parameters perfect, but to restore the alignment enough for the patients to restore their function. She's now 3 months post-op. I saw her 2.5 months out. The last time her leg pain is completely resolved. We also decompressed that area that had the calcified stenosis at L5S1, and her leg pain is completely resolved. She's walking well. Weakness is gone. No more buckling.
Great response. What the next question is, why not an L5 S1 ALIF?
Recall she's fused already at L5S1, so you'd be taking on a fusion mass. Posteriorly, at least, she's fused. So, and if you consider doing an ALIF there too, which you can say you can break through this, you can break through whatever is left of the L5S1 disc space, but she's fused posteriorly, so you have to take that down too. And so I think this goes back again to the goals of surgery for this particular patient. And is this someone we want to get more aggressive, or is this someone you want to restore as best as you can and allow them just to function?
Great response. There are two more questions here. Keep them coming. This is a good time to ask us questions. Do you have any age-adjusted sagittal goals, or do you try to get everyone less than 5?
Less than 5
centimeters of SVA.
Of SVA. So
Yeah.
this goes back to what Dr. Odogwu mentioned when he was discussing sagittal parameters. So we know SVA is a good number to look at, but you see some patients with severe deformity but normal SVA. So if you look at this patient's SVA is corrected to 0, really. If you look at the plumb line from C7. I think I had it here on one of this slide. Yeah, I actually didn't draw it because if you draw a straight line from C7 down, it's actually 0. But there are also studies looking at, we talk about, I think one of Larry Lanke's paper talk about life as a kyphosing event. So as we get older, we lean forward. So we also suspect part of the reason, part is a theory that maybe some of these patients that who develop proximal junctional kyphosis develop it because of overcorrection of the sagittal alignment. So should we be taking 80-year-olds and 70 or patients over 70 to correct the alignment to make them perfectly aligned? Probably not. We think that may actually result to PJK because naturally some of these patients want to lean forward because that's a natural progressive with aging even for a lot of people in the general population.
That's a great question. And, my thoughts on SVA are just like Dr. Manga says, that you sort of use all of this information as a guide. Hence the reason why there was a hesitancy on my part to give you definitive numbers. I would say that if you look at that T9 end plate, the more horizontal T9 is, the better you are. If you look at the global alignment, I would say in my hands, I try to ask myself only 3 questions. Are they balanced? Meaning, if I draw that plumb line, I use the gravity line from the external acoustic meatus, and I want that line to fall behind the femoral heads and in front of the sacrum. Are they balanced? Are they balanced with compensation? Meaning that line falls spot on between the femoral heads and the sacrum, but the pelvic tilt is retroverted, or are they not balanced? If they're balanced, that's great. If they're balanced with retroversion and they have a high pelvic incidence, I know that patient is okay because they have a high propensity to compensate. If they have a low pelvic incidence, that is one that you want to really sort of think about. But the bottom line is you have to make, like in the patient like this, 82-year-old patient is perfectly balanced, excellent correction. I think you do no harm. You try to do the best operation, address the symptoms, balance the spine, which is what Dr. Manga's done here. And then one last question. We have 2 more minutes, but we'll take one more question or maybe another one if you have another one. Any concern for overcorrection in a case like this?
Yes, and I think it goes back to the previous question about performing additional osteotomy at L5 or doing an ALIF at L5. We know if you look at the risk factors for PJK, anterior and posterior fusion also carries a higher risk for PJK. I think there's a paper by Hanjo looking at overcorrection with anterior and posterior surgery. So yes, there's always that risk of overcorrecting some of these patients. This patient is now 5 months from surgery, or 4.5 months from surgery. Is there a risk that she can fail? Yes. Her bone quality is not great. Do we correct her? Yeah, we improve the sagittal parameters based on the numbers that she currently has. We should not expect mechanical failure, but we know that can still happen. So yes, there's always that concern about overcorrection. That's why even with the PSO at the L2 level, I try not to take advantage of the entire defect that's created by the PSO. Part of the reason this was extended to a grade 4 is because, as you see, she had the calcified stenosis from the disc herniation at the L1-2 level. So we needed to take that out. And so that led to a more extensive PSO, but the cage also helped with reducing the amount of correction. So you don't overcorrect the patient by doing now a higher grade PSO.
Great. And this question is actually for me. I haven't used much cement augmentation in any of my older adult patients. I agree with you. I look at a DEXA scan, I check the Helmsfield unit. I try to get them a diagnosis of osteoporosis. so they can get some treatment, especially for the older adults. But I haven't done cement augmentation because the literature has been mixed. Cabatia's studies show that it worked, but there's some other studies that show that maybe it doesn't work. What's your philosophy on cement augmentation? How do you decide who you use it on, and when you deploy it, and where you deploy it?
So I think I started incorporating cement more into my practice maybe over the past 2 years. Going back to, I think, a quick mention of the study you mentioned with Dr. Kavesh. So his study, the early results, 3-year follow-up, 2-year follow-up showed it reduced the risk of PJK if you place cement within the UIV and 2 levels above the UIV. But his long-term study actually showed that there was no significant difference with cement augmentation. So from the same group at Hopkins, the long-term studies actually showed that there was no benefit with reducing the risk of PJK. I'm using PJK in this case more for fixation, not necessarily. I'm sorry, I'm using cement in this case for fixation, and hopefully improve the risk for loosening of the screw, and not necessarily to reduce the risk of PJK.
Got it. Well, everyone, we are at 9 o'clock. Thank you very much, Dr. Manga. Thank you for sharing that case, and very informative and instructive. Please, if you have any questions, do feel free to contact Dr. Manga or myself or any of the AO Spine faculty. Thank you very much for joining, and I wish you all a pleasant evening.
All right. Thanks, everyone, and thanks for hosting, and thanks to AO for giving us the opportunity to present.